Hello and welcome to Unstress. I'm Dr Ron Ehrlich. Now, the purpose of this podcast, just to remind you, is to explore what the words holistic and stress actually means in our modern world. So today's topic of lifestyle medicine covers such a range of those issues and is a phrase, lifestyle medicine, that, well, when you hear it, it just makes so much sense. My guest today is Dr. Sam Manger. Sam is a medical practitioner, an educator, a communicator, and also president of the Australasian Society of Lifestyle Medicine. We cover quite a bit of territory in this episode, and it all ties together nicely with several themes we've covered in other episodes. I hope you enjoy this conversation I had with Dr. Sam Manger. Welcome to the show, Sam.
Hello, Ron. Thanks for having me.
Sam, you're wearing many hats, I know. One of those is the president of the Australasian Society of Lifestyle Medicine, and I know you're a practitioner, a teacher. I wondered if you just actually give us a bit of a background about how your week unfolds and the sort of things that you're involved with.
As you say, many hats. So 2 days a week I work in private general practice, 2 to 3 days, and then 1 day a week I work for Queensland Health, running lifestyle medicine clinics in the mental health inpatient and outpatient. So we have about 1,500 people on our books, and we're trying to develop lifestyle medicine clinics to look after people holistically, because evidence is becoming pretty clear that you look after their body, then you also look after their mind, and we can talk about that a little bit later. There's a lot of interesting research going on there and evidence. And then I spend roughly 2 days a week teaching for James Cook University, lecturing GP registrars and in my region or around Queensland. And then that takes me around the place. So I'm going to Fiji in a month to do a workshop with them on behaviour change and health coaching for their GP training program. And that takes me around. And then I also have my podcast as well, the GP show, which keeps me pretty busy. And then a few other little endeavours, which I'm building as time goes on.
Yeah, wow. And there are only 7 days in the week, Sam. I'm just trying to add all those ones up. You've got a very busy program there. Listen, the word lifestyle medicine, can you explain what that means to our listener?
Yeah, sure. So lifestyle medicine basically means any lifestyle intervention that can be used as therapy. So it's anything that is not supplements, medications, or surgery, and not that those don't have their place, but it's just not what lifestyle medicine is. And that includes nutrition, movement, mind-body interventions, sleep, connection with each other, connection with nature, and behavior change and health coaching techniques. And then often we couple that with apps and technology that's coming out these days that could be used, i.e. in health coaching. So that's the clinical aspect of lifestyle medicine. And then you've got the advocacy and public health aspect, where we work with many universities and research institutions to start developing a very decent base of evidence for these interventions, nutrition in heart disease or mental health, for example, or sleep therapy and dementia. And then working with universities to try and get this into the core curricula, or at very least an elective placement for medical school placements and dietitians and allied health and nurses, because it would be very common, I'd say now at the moment, most weeks, that I would get an email from a medical student or a GP registrar who wants to do a placement in lifestyle medicine. And so now I'm, through the organisation, searching for members who want to take them on, and people who fellowed with our organisation or certified. And that's great, because people want to teach it, and there's starting to become a real career in it, which is refreshing. And likewise, I get almost most days now, but definitely most weeks, emails from NGOs and businesses and organisations who want to open up lifestyle to be a part of their program, whether it be a corporate program or a NGO that works on mental health or post-traumatic stress disorder or something like that. They want that as well to be a part of it. So they're contacting us and looking for people to help them. So it's a pretty broad range, but I suppose if you look at it, we're trying to approach every level of the health system and society in a way.
Before we dive into those kind of things, I'd love to get your impression of where we're at health-wise, your assessment of our current state of health. How are we doing?
Oh, it's a tricky one. Look, I think that we're looking, if you look at the stats, 50% of people have chronic disease at the moment, 25% of people have 2 or more chronic diseases, and 50% of people over the age of 65 are on 5 or more medications to manage those chronic diseases. And I think it's about 60% of people over the age of 20 are on at least one medication.
Wow.
Medications cost roughly $20 billion a year, and the health expenditure is about $160 billion a year. And whereas primary care only costs about 10 to 15 billion. So we actually spend less on GPs than we do on medications. And the vast majority of that money goes to the hospital sector because we're working on a downstream model, meaning that we catch people when they're sick and try and fix it then when it's, that's good to do. It's tertiary and secondary prevention. But ideally, we need to now start looking at this primary prevention, or at very least when we catch people, let's say with diabetes, heart disease, we can use lifestyle first line and then reverse it with that, not needing medication, and actually truly reversing as opposed to just managing it. So I think the health system, I have a lot of respect for it. I think, working in it, I know that everyone has a good heart. They're working hard. But the model is not built for the chronic disease issues we're seeing now, and it just needs to evolve as it always has.
Because I agree. I mean, I think one of the things that, because obviously I'm very involved with nutritional, environmental medicine, and one of the things that I think all practitioners that I know, and some are in that chronic management model and others are in the integrative holistic space, one of the things they both have in common is they want the best outcomes for their patients.
Absolutely. Yeah. I think for the most part, I mean, there's always exceptions to the rule, but for the most part, every doctor, nurse, allied health person I know, regardless of their philosophy on health, of which there are many, on the spectrum of sort of conservatism to progressivism, that they all do want the best for their patient. They just have a slightly different interpretation of how to get there. But we're now just reaching this challenge where simply the numbers aren't in our favor anymore, and time is so pressured that even people like me who want to deliver much more holistic care, it's very hard because neither the financial model suits it nor the time model. It's very hard to deliver good quality care in 12 minutes. So things need to change in that way.
Well, I was going to say what are the barriers, and I think it'd be good to go into that, but you're involved in medical education at an undergraduate level, and I don't know about when you went through medicine, Sam, but I know when I went through university in dentistry, the nutritional aspect of what was causing, or lifestyle aspect that was causing so many of these diseases that we learnt so much about, it wasn't being given a lot of time. Was that the case for you when you were going through?
Yeah, it was. I think it's a tricky one. One of the things I often hear criticisms of doctors is that they don't get taught any nutrition. And I think that is true to a degree, but I think there's also, it's more nuanced than that. So what is nutrition? I mean, nutrition is biochemistry, essentially. And so doctors get taught an enormous amount of biochemistry. We know all about the citric acid cycles and, all these sorts of things. The bit of information that we're missing is how to use that in a clinical space as therapy. Okay, which diet is best for which condition, and how do I help people or coach people to apply and change their lifestyle to do that? That's the bit that is missing to me. And so that needs, I do believe, needs to be put eventually into the core curricula. The problem with medical school is that, and it's not a problem, it's just a sort of a fact of reality, is that you have 4 years, you have to do your pre-med of 3 years, you then do medicine of 4 years. There is an enormous amount to learn. I mean, when I was doing medicine, you go to uni, you study all day, you get home, you study all night. That there is no, it's not like any other. I did a science degree and that was pretty laid back. You just cram before the exams. But medicine was nothing like that. You study the whole time for 4 years. So it's not like they're not, it's not included because they don't have anything to do. It's just a competition thing. And you've got to finish medicine able to save a life of a person with a heart attack or with trauma, something like that. So that's the priority and that's what they teach. And then, so the reality of getting this into med school probably is not feasible in the short term. What we'd like to do is get it as an elective for people who want to do it more. But where we do need to get it in is the specialty training programs. So cardiologists, when they're doing their cardiology training, should be learning about how to reverse heart disease with lifestyle medicine, but they're not. So that, I don't think there's much excuse for that. And GPs who are learning should be being taught lifestyle therapy as well. And they are a little bit, but not as much as I think that they could be. But like I said, I don't think that's anyone's intention. There's no malevolence there. It's just not in the system.
I've often said that if I had a choice of what I would go back and study rather than do a PhD, I would go back and study anatomy, physiology, and biochemistry. Now, if I was taught biochemistry in unison with nutrition, it would have been fantastic. I would have gone, wow. So that's why I'm learning this cycle, and that's why eating X, Y, or Z is important. Or anatomy and physiology and chronic pain management. That would have been fascinating too. But they were subjects that we kind of just had to get over before we got into the real stuff.
Yeah, I agree with you 100%. And it's so interesting because now when I teach, I bring up, the citric cycle or something like that, or electron chain transfer or something like that. And I'm like, so this is why you need B vitamins.
Yes.
Because it's involved in all these steps. And people are like, oh, I get it now. That's why you need to eat your broccoli. So it's like you can actually start piecing it together in a much more meaningful sense as opposed to, exactly as you said, just learning it for learning its sake.
Yeah. And you use that word, Sam, holistic, which of course conjures up all sorts of things when people, they kind of think of crystals and some kind of new age philosophy, but actually lifestyle medicine and holistic is kind of synonymous, really, isn't it?
Yeah, you're right. It has a lot of connotations to it, and as does lifestyle, sadly, but that's just the way it is. But so holistic, I mean in the term of the whole person. And so what is that whole person? Well, they're biology, but they're also psychology. And there's a huge impact between the mind and the body, which is fascinating. And then they're their environment with which they exist in. So they're the culture which they're a part of, the everyday environment. And so when I talk about holistic, I just mean taking all of that into account when we're talking about the person rather than just a minutiae detail like a blockage in their coronary artery or something like that.
So let's go through some of these things that constitutes lifestyle medicine, which we can talk about, which practitioners and patients should be learning about. Let's go through a couple of them.
Sure. Where do you want to start?
Well, why don't you pick somewhere? Where would you start? Not necessarily in order of importance? If someone had to say to you, what's the most important aspect of lifestyle medicine, Sam? How do you answer that?
Well, it has to be personalized. That's the truth of it. So, because everyone's lives and factors in their life are unique. So some people have not a bad diet, but they're incredibly stressed, and so you have to work at that level. And some people are sleeping very poorly. So they might have sleep apnea, or they may just have insomnia or some other thing. And so that's going to be one of the bigger things. So to be honest, when I'm in my clinic, the first place I start is not with advice, but with taking a good history. And when I take a detailed history, it starts to become clear what areas need to be, approached. And whether it be nutritional, sleep, or movement, or wherever it is.
And well, on a practical level, what sort of time are you allowing in your clinic for a new patient exam?
Well, most patients are booked in first appointments with me for half an hour, and that's just the standard GP practice thing. And I can get some done then, usually more a screening, get to know you kind of thing, and then I will often book them up. And it can take me 2 more 30-minute appointments before I've got to the depth that I feel I needed to get to. So at least an hour to an hour and a half, but sometimes that'll be over a couple of weeks.
And you mentioned that the barriers for implementing this kind of approach are both financial and time. How do we overcome those? I mean, is it just a philosophical decision that a doctor has to make?
Yeah, I think, the MBS, which is, the Medicare benefit schedule for GPs at least, is based on time you spend with the patient. And per minute of time, you get a lot more money for spending not much time with patients than you do with more patients. So the incentive, it's actually extremely hard to keep a GP practice afloat by seeing people for longer periods and bulk billing them, which I bulk bill the vast majority of my patients. And so you've got this real conundrum where, okay, if you need an actual viable business, to pay your nurses and reception, you need to either charge a gap or you need to see people for a shorter amount of time. And that's just the nature of the beast. Now, the MBS is being reviewed and we're hoping that that's going to change, but I can't see it changing enormously anytime soon. But with healthcare homes, which will come out in the next couple of years, may have an impact there, which is a different funding module for primary care. So the way I go about it is I just accept the limits, and I see people more frequently and for 15 to 30 minutes, and I sort of drip feed out the intervention, which I actually find works anyway, because when it comes to behavior change and health coaching, if I spend an hour with a patient, it's often too much information for most people, so they can't process it all, because it's too much information for anyone really to hear all this sort of stuff and go, okay, you need to change this bit, this bit, this bit, this bit. It's much easier if I go, okay, well, let's just change one or two things this time, and then I'll catch up with you in 2 weeks and we'll change one or two things that next time. And over, it can be a little bit more slow, I suppose, or it seems theoretically slower, but after 3 to 6 months, you've actually made an enormous number of changes, and you've supported them the whole way. You've developed a very good relationship, and I find that very rewarding. I mean, that's I think why most people get into health is the connection that you have with your patients. So that's how I work my way around the system. But I also find that the more I do lifestyle medicine, the more efficient I become at it, and so I can assess pretty quickly where I think the low-hanging fruit is, or where I think the major issues are. And I also know, I've seen it many times, I know the evidence, so I can target my advice accordingly. So the more you do it, the quicker and the better you get at it.
I mean, I like that, because, we have this idea that, oh no, I've got to set aside this hour and a half because I'm wanting to be all things to all people all at once. And that is a problem. But this kind of slower approach is realistically how one can incorporate it into a practice, but it's probably practically a better way of doing it with your patients.
Yeah, and they don't seem to mind. I mean, I will often make sure my first appointment is I get a big, scoping assessment, and not just from a lifestyle point of view, but from a medical point of view, making sure there's no red flags or nasties that we're missing. And once they're ruled out, then we focus on the lifestyle areas. And I will say, okay, well, today we're going to talk about, which one do you want to talk about? I mean, again, personalizing. Okay, I think this is probably the most important factor. Which do you think is the most important factor? And they'll say, well, it's my relationship with my husband is the biggest issue. I'm like, oh, all right. Well, then let's sort that out first, because that's obviously of crucial importance to you. So it's a very much a partnership. Lifestyle medicine is based on that sort of shared management.
And patients' response to this? I mean, people come in, I guess they come into you, and your reputation must inform them that something different may happen here. But people often come in with an expectation to a medical practice that isn't kind of switched on to anything other than what they've been exposed to throughout their entire life.
Yeah, I think I certainly have experienced that, and that's a really big topic because on the one hand, patients, they do come in and they're either seeking me because of that more holistic inverted commas approach, or they just happen to stumble across me and then they realize that's what I'm doing and they're really pleased. They say, wow, no one's ever talked to me about this before. And they're, really, really happy about that. But again, it's not the problem with speaking like that is it's almost I'm insinuating that other doctors don't do it, and I'm not insinuating that. I know a lot of other doctors who do this good work, but there's no doubt a strong desire from patients to at least have this as an option, and not to be the only option, to have other tools in the toolbox. But they're very pleased when it's raised as an option to go with.
I mean, you were talking also about your work with Queensland Health and the mind-body connections. I wonder if you might just talk to us a little bit more about that, because mental health, of course, is a huge and growing problem in our society. What are we seeing out there? What are we seeing in mental health issues?
Well, mental health is a real challenge. I mean, what the RACGP had a report recently, which is the College of GPs, showing that mental health was the most common presentation to general practice, and the World Health Organizations have said depression is the leading cause of morbidity worldwide now. Wow. So we've got a real challenge, and the good thing about lifestyle medicine in the context of that is it works at two different angles. So it's one solution for multiple problems. So if we take depression, anxiety, but then the more severe mental illness like schizophrenia and bipolar. So commonly what we see with schizophrenia and bipolar is that people actually die about 20 years younger than the average population because of metabolic disease, largely in COPD. So it's not actually because of their illness they're dying. So we talk about close the gap with Aboriginal health, which is obviously incredibly important. And that's about 8 to 10 years between Aboriginal people and non-Aboriginal people. But it's about 20 years between those with severe mental illness and those without. And that's because of the medication side effects, partly because the weight gain can be so significant on some of them, but also because of their lifestyles. That they often are smoking, they're often not eating well, they're not well supported, they can be homeless or itinerant, and that they present all these challenges. And of course, I'm not labeling everyone with these things, but there are pockets. And so lifestyle medicine treats that because if they're dying from heart disease and COPD and liver failure and those.
COPD, just give us, I know it's an acronym and I know what it stands for, but go on.
Emphysema, so okay. Chronic smoking lung disease.
Yep, go.
If they're dying from those things, well, if you help them quit smoking and you get them to go on a good lifestyle and their heart disease reverses and their fatty liver disease reverses, then you've now closed that gap. But the really amazing stuff is the evidence now in the last only probably 2 or 3 years coming out, the impact of those lifestyle measures on their mental health themselves. So if you look at movement as an easy one to talk about, we know pretty clearly now that, I don't like the word exercise, but so we use physical activity, but physical activity is as effective as antidepressants and psychotherapy in depression. Wow. But also it's extremely effective in reducing psychotic symptoms in those with schizophrenia. So we now have a single therapy that improves a lot of mental illness. We now know that people with major depression, like as in severe major depression, who go on a Mediterranean-style diet, a third of those people will go into remission. And this is from randomized controlled trials. So if you've got an intervention, let's say movement, physical activity improves a third of people, and you've got nutrition improves a third of people, that's a lot of people with depression that you're reversing without medication. And then you've obviously got sleep, which is a huge one. And we know, for example, with sleep that people with depression are 4 to 10 times, well, people with sleep apnea 4 to 10 times more likely to have depression. And I think, like off the top of my head, about 15 to 20 times more likely to have anxiety. And insomnia is strongly linked to delusions in people with schizophrenia, which is a type of psychotic symptom. And so we know clearly, okay, sleep seems to be correlating with all these negative symptoms. We also know that it correlates with treatment resistance, meaning you give them medication, but they're not getting better. Okay, and then we start to go, okay, what happens when we treat that sleep? And trials are now starting to show that when we get people sleeping a good quality 7 to 8 hours at a reasonable time, then the depression improves, their treatment resistance resolves and things like that. And I've certainly seen that. So we've been running some projects, some research projects where I am at the moment looking at sleep and doing sleep studies. And I am amazed how common severe sleep apnea is, and you as a dentist would obviously see this as a big thing, and it's quite stunning. So these patients have been walking around severely sedate and thought to be the medication, and then I started there. I said, okay, well, maybe we should look at their sleep. Let's get a sleep apnea study. And they had severe, I've never seen a report like it. The specialist wrote very severe sleep apnea. I never put them in that very before. And we gave them CPAP, and then one person needed a mandibular splint, and as that does need, sometimes actually works really well. And they just woke up, boom, next day, just like a new person. And no one could believe it. And so now this person wanted to start exercising, start eating well, because they had the energy to do it. So we were well and truly on the path now to a better outcome. And the whole, the different unit, I work at 4 different units, but the culture changes because now this lifestyle is part of the treatment pathway. And that's really lovely to see. I mean, there was a bit of resistance from the previous culture, as it were. You know, people didn't think that lifestyle had its place. It was medication, psychotherapy, that was it. But now now you're seeing the benefits to the patients. People are like, okay, this is it just has to be part of the treatment now. So that's what I'm hoping to see unfold in the future, that it is just an accepted part of therapy.
Yeah, and it's so simple. I mean, what's so almost unbelievable about it is that it's actually remarkably simple to ask that question. It surprises me how often, when taking a history of a patient, they're on antidepressants, and my next question is, have you ever explored your sleep pattern? And a lot have not. So this is exciting to see this happening in practice, because it's a huge difference. If a practitioner's listening to this, and I know I do have a few practitioners that do listen to this, and they were wanting to incorporate this into their practice, what would you advise them? How would they get started in that journey?
Well, I think twofold. One is how you approach the patient. The second is resources. So how you approach the patient, my advice is not to go away and start reading about the latest or what you think the best diet is, whether you think it's low carb, keto, or vegan, whole food, plant-based, or Mediterranean diet. Not to get sucked into that. I would just take a really decent lifestyle history. To me, that's where it starts. So nutrition, what do you want to know? You want to know what they have for breakfast, morning tea, lunch, afternoon tea, dinner, after dinner, before bed, and overnight, because overnight snacking is a very common problem. You will never know unless you ask. And then you want to know about drinks, coffee, milk, sugar, tea, added sugary drinks in particular is a major burden. And then movement. When do you move? Why do you move? Why is a big, important question. How often do you do it? What do you like to do? And what did you used to like to do? Sleep. When do you go to bed? How often do you wake up? Do you wake up tired? Do you snore? Do you get headaches in the morning? Those sorts of questions. And then connection, how many people in your life would you consider that you would really connect with, that you could tell your really, your deep worries to? And often it's like 0 or 1. And that's not healthy. We're tribal creatures, and we need it probably at least 3 or 4. And so if you take that history, the management becomes kind of obvious, because you can have a person, I could go through any number of examples, but a patient the other day, I took a dietary history. And what typically happens in a consult is people say, "Do you eat well?" Yep. Okay, good. That can't be it then. Can't be the problem.
That's right.
And that's as deep as it gets. Or they say, "Okay, well, you know what? You're eating too much junk food because you told me you're eating junk food. So here's a 1-page handout on the healthy eating guide, and I want you to go and do it." I mean, that is never going to work. So you need to personalize it. It could be that I had one patient the other day who was having between 10 to 20 Cokes a day, but they were eating really well other times. So of course the major issue is their Coke, but you have to ask them, why are you drinking that much? Well, probably because they have a binge eating disorder or something like that. So it's like, okay, then you need to treat that. That's your management. You can't give them a 1-page handout, because it's going to mean nothing to that person. It's going to be completely pointless. So it could be some people eating overnight because of their antidepressants. It could be that they're eating 1 meal a day and it's not a good meal, or it could be that they're having 5 meals or whatever. So you have to personalize it. And it goes the same with sleep, same with movement, same with connection and nature time and those sorts of things. So I don't try and get too hooked up in the advice. I try and get people to be curious, be detectives. Also, one, because it'll make the management more obvious. But the second thing is it develops a relationship with your patients, because when people feel like they're listened to, because we're all human, when I feel like I've actually been heard and seen for all that I am, you now trust the person who's doing that with you. And when they then make it a suggestion, like, hey, maybe we need to really work on your, Coke intake, or maybe we need to work on that, all that bread that you're having, or whatever it is, they'll go, yeah, okay, because they trust you now. They trust your opinion. If you don't spend time developing that and you haven't listened and heard that person, then they're going to be more resistant to it, because you're now an outsider. So my advice is to not get hooked in the current and very strong current of nutritional debate and things like that, and more just get involved in the patient that is in front of you.
Mm-hmm. Yep.
As far as resources go,
yeah.
Look, there's plenty of good resources out there. I mean, obviously the Society of Lifestyle Medicine and your college will have various resources, and they can check them out on the website. And there's the lifestyle medicine textbook by Professor Gary Egger, is sort of like what I would call the Murtaghs is the key general practitioner textbook, and the Egger book is the lifestyle one. And then there's Ripe, which is the American lifestyle medicine textbook, and then there's Mechanic, which is the European one. And then there are various other formulations of that. And so that's as a general thing. And then if you've got a specific area of interest, like say behavior change or health coaching, then you could look at Margaret Moore's book, Health Psychology Coaching Manual. I think that's a fantastic book. And then if there's other specific areas of interest, let's say you want to figure out how to build rapport, there's some fantastic books by William Ury called Getting Past No and Getting to Yes. So they're two short books on how to what it sounds like, getting to yes and getting past no. So developing and diplomacy with your patient and shared management, and they're fantastic, short, concise books. So when you start taking history, again, I sound like a broken record here.
No,
when you start taking history,
it's important.
You actually then realize your own deficiencies. So you'll go, actually, I just can never seem to get this person to agree with me or to actually do what I'm asking him to do. So I must not be a very good salesperson. I must not be a very good coach. And I think that humility is really important because I go through it constantly. Or you go, okay, this person just asked me about the best diet for reversing diabetes or heart disease or whatever it is. I actually don't know what that is. So I'm going to go and do my reading in whichever area that is. But there are certain good places to start, and those would be those resources that I just listed. And of course, PubMed is always going back to the original studies themselves.
It's so interesting, the connection issue, isn't it? Because that is, it's proving to be so huge. I think Harvard did a 75-year study and found relationships was the biggest predictor of health, wellness, longevity. But now, as we are faced with so much technology, our connections are a bit odd. And I know that young people are suffering mental health issues. This is a big challenge too, isn't it? Our relationship with technology.
It is fascinating. So I think I heard someone call it technopathy the other day.
Technopathy, okay.
Yeah.
That's a new one. I'll write that down.
So, technology is an interesting one, right? It's sort of like a car. You can use it to get somewhere, or you can use it to kill someone. I mean, that it's inherently it has its problems, but it could also be used for good. And there's sort of, you can look at it on both ways. So you're absolutely right. Social media these days, in particular, Twitter and Instagram and Facebook, the constant classic stereotypical things you hear about, people posting their best life and everyone else feeling like they're not living that and insecure and unhappy about that. And I think that's definitely true. And also the trolling and bullying that goes on online is obvious. But when you look at the number of people, when the studies look at the number of people that you would count as your clear and closest friends, as I mentioned before, someone you could really confide in, it's gone from, I think, about 15 years ago. So social media really gets, Twitter was 2007 and Facebook a couple of years before that. But in the last sort of 20 years, it's gone from, I think, 2.5 people to now 0.9.
Wow.
So we've got these massive networks of people, but no one we trust and no one we really think understands us. And that's a horrible, lonely position. And in fact, what we see when you actually ask people about loneliness, that is going up significantly. People are feeling much more isolated and lonely than they have before. And it's, as you say, ironic considering we've never been more technologically connected than we have before. But it's not real connection. It's not sincere connection. And I think it's going to be a good thing because I think humans are going to realize, us as human race will realize that. And I think we're starting to already. You're actually seeing Twitter use go down quite a bit now. And Facebook starting to consolidate into groups more than just general single posts, if you know what I mean. So they're forming communities. So it's a very interesting evolution of that. On the flip side, technology is interesting because let's say, I don't know if you've done many podcasts or done much reading on the avatars and augmented reality and things like that. So you've got avatars which are essentially fake people, but are like machine learning, not artificial intelligence because we don't have artificial intelligence, but they're just sort of computer programs that can respond like Siri in a way for your phone. And what they're finding is actually you have an avatar on the screen talking to a teenager, they actually trust that avatar and confide in that avatar more than they would their other therapists. So it's a very interesting thing and that's not obviously for all people, but in certain people. And it's interesting that we feel at the same time when it comes to technology less judged and less we can drop our barriers. It's like talking to our dogs because we know they don't respond back. We feel like we can give them everything we've got. And so there are uses for technology which I think are incredibly therapeutic and beneficial, and then there are ones that are incredibly negative and damaging. And so we will, with time, learn how to mature that relationship.
Yeah, I kind of think with technology, we're a bit like kids in a toy shop. We want everything, we're taking everything, but then we're realizing that perhaps everything isn't what we need. But we're kind of, I said, well, if a practitioner was wanting to get started in lifestyle medicine, you've given us a good overview there. What about if somebody was listening to this and going, yeah, I think lifestyle, I've got to look at my lifestyle. Where, what would you be saying to them? What would you say to patients? I mean, I know personalised, I take that point, but what do you say to patients or people listening to this?
Well, as general rules, when it comes to nutrition, you want to focus on real food, and that it means no or minimal processed food or highly refined foods. So that includes grains and oils. So you can have whole oils, so that'd be like avocado oil, olive oil, flaxseed oil, those sorts of things, no problems. Lots of vegetables, can't go wrong with that. Nuts, seeds, herbs and spices. If you're going to eat meat, some people do, some people don't, then try and make it grass-fed and or wild. And whole grains are generally fine. Obviously, there's situations where some people don't tolerate them, and so that's, essentially the Mediterranean diet in a nutshell is a good place to start. And from that point, you may find that you need to go more in one direction or another based on your unique biologies. There was an interesting trial in 2015 in, I think it was Tel Aviv in Israel, in the journal Cell. And they looked at, I can't remember how many people, but let's just say it was 100 people, and gave them all exactly the same amount of carbohydrate. And sure, there was a big spectrum of how people responded to that. So some people, no blip in their sugar or insulin levels. Some people, significant. So we know that there are some people who respond more in a negative way to that, and some people who just tolerate it no problem at all. And in fact, it seems to be very beneficial. So I don't prescribe to a one-size-fits-all approach, but I do think as a general rule, you can't really go wrong with fruit, vegetables, nuts, seeds, herbs, spices, legumes, pulses, lentils, those sorts of things. The epic debate that's going around now in the last couple of years about insulin theory of obesity and low carb versus high carb and low fat, all this sort of thing is painfully painful, but interesting as well. And we could talk about that, but we're probably going to run out of time. But it's not as simple as people think. It's not as simple as carbs equal insulin and everything doesn't. I mean, there's certain carbs, for example, porridge has a lower insulinogenic response than does steak. So it's not as clear cut as just one food group versus another. And then movement, I would just encourage people to move for pleasure, not because someone's telling them to do it and not for a goal in mind, but just move because it feels good and it makes you happy to do it. Because when you start doing that, you'll do more of it, and it's that simple. So ask yourself, what do I enjoy doing? What do I fantasize about doing? Or what did I used to enjoy doing? And then just pick 5 minutes. Rock climbing, dancing, drumming, walking, swimming, I don't care what it is, but just get out there and do something along those lines. Sleep 7 to 8 hours, just do it. Like, there's a lot I could say on sleep. We all need the 5 cycles of sleep that are roughly 90 minutes each, hence 7.5 hours is where the recommendation comes from. And some smaller cycles, some longer cycles, but just get your 7 to 8 hours. There are very, very few people who can survive on less than 7 hours consistently, and you're just lying to yourself, because the studies are very clear that people who are sleep deprived have exceptionally poor insight into how sleep deprived they are and how much that impacts their cognitive abilities. So just because you think you're doing fine doesn't mean you're doing fine. Still try and get 7 to 8 hours. Despite all the stuff I do with my life, I still get 7 to 8 hours. I prioritize that.
Non-negotiable life support system. It's a recurring theme of this podcast. Go on. I love all this, Sam. This music to our ears.
Good. Stress is obvious. That's your podcast, and you're all about. And so that's obvious that you've got to try and switch on the relaxation responses as often as you can. And that can be simply smelling a smell and being mindful of the experience of a sight, or more classic things like progressive muscle relaxation or meditation. There are plenty of ones that are out there. And then connect. Find people that you. There are certain conversations like the one we're having now, perhaps, but where you just lose the concept of time, and you just thoroughly enjoy it. You finish the conversation, you have more energy than when you started it. They are the kind of conversations we should be having more of. So you need to find the people in life who give you that feeling, and actually proactively commit to putting in a bit of effort to catching up with them on a semi-regular basis, once a week or once a fortnight. Don't hassle them. Yep. But hopefully they get the same experience from you. And so they're the kind of relationships we need to foster. And then nature time, again, the evidence is fascinating when you look at the impact of nature on our mental health, but also on our very biologies. I mean, there was a very interesting repeated studies showing that people who are in hospital post-operative in pain, who were able to view outdoors nature or even view the sun and the sky, had about 20 to 30% less pain relief requirements than those who didn't. So we know it's actually deeply impacts our biologies. So get out in nature at least once a week, because we were evolved to be in it every day. So we've got to try and mimic that. What situation do we evolve in, and try and mimic that as much as we can. And then all the other stuff we talked about, spend an hour going through your Facebook feeds and block every single thing that makes you feel down, except maybe the occasional bit of news. And if you want, and then actively sign up to things that make you feel better. Like we can control our environments probably more than most people would appreciate. And don't be a victim. Take power back.
Well, that's just fantastic, and I love the way we've kind of almost sandwiched just eat real food and connect with real people, and connect with nature. It's kind of sandwiched all those other lifestyle things in between. And listen, we're just finishing up now, because this has been fantastic, Sam. You've given us so much information, so much to think about. Taking a step back from your role as a doctor, an educator, because we're all on this health journey together, what do you think the biggest challenge is for people today on their health journey through life in our modern world? What do you think that might be?
Well, I think that well, it depends on which level we're going to talk about. So at a cultural systemic level, all these things are, disconnection from real food, from ourselves, from each other, is becoming part of our culture. And that's a real challenge to go against the tide of what people are being raised in. So we have to raise awareness and encourage people to reconnect to those elements of life. So that's a major challenge that I think we all face. From a point of view where people are kind of interested in health and are going down that path, it can be incredibly overwhelming, the amount of information out there and the amount of disagreed opinions, especially in nutrition. And so that can be very confronting. And I think that you have to develop a relationship with probably a therapist you trust and go from there. And I'm more along the philosophy of, rather than give a person a fish, teach them how to fish, that sort of philosophy. And so I wouldn't necessarily tell people what the right style of eating for them is, but rather I would encourage them to learn of their own biases, learn what they may want to be true, and question themselves. And then whoever's telling them, question them as well. Don't believe anything at face value. Learn the principles of how did they come up with that opinion? What is the evidence, and how do I look at the evidence myself so that I can make my own decision? Because I've read books on all kinds of things, and I've been convinced at the end of that book that this is the way. And then I go and look at the studies with which that book was based on, and I realize that they definitely misinterpret those studies to make themselves a book. And that's really disappointing to me. And I'd say that I've seen that on every spectrum. I've seen that from low carb advocates. I've seen that from low fat advocates. And so you have to, in essence, just go, okay, I appreciate your opinion and your interpretation. I respect that, but I'm going to go and do my own research. and I'm going to learn how to analyze data in its real sense. And that could be a big ask, but sadly, I think that we all need to be filters in a way. And then we need to develop a relationship with a doctor or a health coach or a dietitian or an exercise physiologist or a dentist, someone we trust enough that we can then banter with and say, well, what do you think about this? And hear their opinion and get another side of the story. And so we're always going to need our health professionals, but I would just encourage people to, as I said, learn the principles which underlie these things.
Sam, thank you so much for joining us today. It's been terrific. I'm going to have links to that, the ASLM website. I think it's fabulous resources there. So thank you so much.
Thanks for having me, Ron.
So there it is, quite a lot to think about. Interesting to hear Sam's advice to practitioners wanting to incorporate more lifestyle medicine into their everyday practices. But 3 ideas stood out for me. The first one is personalised. Whether that is the approach your medical practitioner is taking or not, it is definitely the way medicine in the future will be practiced. Personalised medicine. It also means for you to personalise things. The advice you receive. Where are your weaknesses? Is it sleep? Is it breathe? Is it nourish, move, or think? Focus on one at a time. Don't overwhelm yourself. Play the long game. It's called life. Work out what is right for you. What do you enjoy doing? What stresses you out? How well are you sleeping? Another idea is the word real, and it's a recurring theme. Just eat real food. Very simple, uncomplicated, no controversy there. If it doesn't come in a packet, if it's not processed, well, it's probably good. Focus on fresh, whole foods, vegetables. Everyone agrees with that one. Moderate amount of ethically grown protein is another one, and fats, for that matter, healthy fats. The third idea that I thought stood out was connection, and it's summarised in that word connection. It's another one of those ideas we have referenced before. Value the connections of real people in real time. It's disturbing to think that 15 years ago, when people were asked, how many people close to you could you rely on? The average was 2.5, 2.5. Today it is 0.9. It's hard to find 0.9 of a person. While we are more connected with the world, we are less connected with the people sitting right next to us, or our neighbours, or our community. And this social isolation is a huge challenge to our physical, mental and emotional well-being. Sam used the word technopathy. Now, I hadn't heard that before, but it's a good one. While technology gives us access to so much information and does allow us to keep in touch with many people, it also has many problems and challenges. Well, for one, the fact that Wi-Fi radiation coming out of our phones and personal devices is now considered by the World Health Organization as a Class 2 carcinogen. That means it is a possible cause of cancer, and it's everywhere, so it is a real problem. But there is also the psychosocial challenges connected with technology as well. The fact that people are feeling more isolated, more lonely. Anxiety and depression are a big problem, a bigger problem than ever before. I believe that's no coincidence. Technopathy, wow. Look, I'll have links to the Australasian Society of Lifestyle Medicine website. It's a great website. I hope you enjoyed today's program. So until next time, this is Dr. Ron Ehrlich. Be well. This podcast provides general information and discussion about medicine, health and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner.